Welcome everyone. We will discuss the CBT FMGE medicine portion. Starting with question number 1. Question is a patient presented with fever and neck rigidity. Patient CSF was done and which shows 75% of lymphocytes with a CSF to plasma glucose of more than 50%, and protein levels are 0.5 gram per deciliter, which is almost normal. So what is the diagnosis? Bacterial meningitis. In the bacterial meningitis, the cells will show predominantly neutrophils. Here lymphocytes are given, and as well as the CSF glucose will be low. CSF plasma glucose ratio is less than 50%. So CSF to plasma glucose will be less than 50%, and proteins will be elevated, which is given here is almost normal. While in viral meningitis, it is lymphocytic response, lymphocytes, and that CSF plasma glucose ratio is more than 50%, and proteins are near normal. So this is viral meningitis. While in cases of the fungal meningitis and tubercular meningitis, the ratio, the CSF to plasma glucose ratio is less than 50%. And in tubercular meningitis, the proteins will be raised, elevated. So the best diagnosis, B option here. Moving on to question number 2. Most common artery involved in a lateral medullary syndrome is, so the lateral medullary syndrome is also known as a Wallenbach syndrome. So the most common artery involved is the vertebral artery, though posterior inferior cerebellar artery also lead to the lateral medullary syndrome, but most common being a vertebral artery. Question 3. A young patient has sudden onset of severe headache, but he has never had a headache as bad as this one. He is hypertensive and having neck rigidity. There is no fever. Next line of investigation. So this is most likely a diagnosis of subarachnoid hemorrhage. The most common cause is trauma, followed by the hypertension, rupture of Barrett's aneurysm, and the typical symptom is the worst headache of the life, but there will be no fever, though neck rigidity can be present. So presence of fever will go in favor of meningitis, absence of fever, subarachnoid hemorrhage. So the initial investigation should be a non-contrast CT head which should be done, and it will reveal a subarachnoid hemorrhage. But if it is not conclusive, so in that case we will go for a CSF analysis, and that will show us xanthochromia. So answer here will be NCCT head. Next question, question number 4. In Brown-Sequard syndrome, which manifestation is seen on the contralateral side? So if we see this is the spinal cord, and suppose this is the midline. So the fibers which comes from the contralateral side and then ascend, they are spinothalamic tract. So spinothalamic carries the pain and temperature sensation, while the fibers which ascend on the same side, these are the posterior column, and posterior column is responsible for the vibration and position sense, while the other pathway which descend in the same side, that is a pyramidal pathway. So pyramidal pathway is responsible for the motor power. So if there is a one side damage of the spinal cord, so the same side ipsilateral vibration loss will be there, ipsilateral position sense loss will be there, one side of the spinal cord, while the same side ipsilateral limb paralysis will be seen. Red one you can see pyramidal pathway, while the spinothalamic is coming from the opposite side, so the pain and temperature loss will be of contralateral side. So the answer here will be a D, that is a pain loss will be of contralateral side. Rest of these will be ipsilateral. Question number 5. A patient has ptosis aggravated by the end of the day. What is your first differential diagnosis? Though the typical feature of a ptosis which is aggravated by end of the day or fatigue in the evening time is highly suggestive of myasthenia gravis. So the myasthenia gravis, the very specific test which should be done is the acetylcholine receptor antibodies. They are most specific test for the myasthenia gravis, and bedside test will be ISPEC test. Bedside test. So ISPEC test, the ptosis will improve with the ISPEC test. And the treatment consists of pyridostigmine, but if it is a generalized myasthenia gravis, then we will go for a thymus removal. For crisis, go for IVIG. So if it is ocular, the treatment will be pyridostigmine. If it is generalized, pyridostigmine plus thymus removal, thymectomy. While if it is a crisis, then we will go for IVIG. Question number 6. Which of the following drugs should be started in a patient of absence seizure? So ethosuximide is the drug of choice, but that is not given. Our best response will be valproate. So if ethosuximide was given, then it should have been the first choice. Question number 7. Question is Osborne wave is seen in. So basically Osborne wave is, say this is a QRS complex, and after the QRS complex there is a J point, but instead of a point, if there is a wave, this is known as a Osborne wave or a J wave. The causes of this condition, the most common cause is hypothermia. Other causes include hypothyroidism, hypercalcemia, subarachnoid hemorrhage sometimes can also lead to the Osborne wave. So answer is hypothermia. Question 8. A patient complains of palpitations. On examination, ECG shows absent P wave, and in this question, regular rhythm or regular heart rate is being mentioned. So whenever there is a tachycardia, that is a palpitation with the absence of P wave in the ECG, there will be two diagnoses, absent P waves. One is atrial fibrillation, second will be PSVT. The difference is very easy. Atrial fibrillation will have irregular rhythm, and PSVT will have a regular heart rate or regular rhythm. So answer will be PSVT in this condition. Prominent U wave, absent T wave, and prolonged PR interval is seen in hypokalemia. So hypokalemia have predominantly U wave is increased, the T wave is reduced or maybe absent, and there will be a PR interval prolongation. Sometimes P wave can be tall, that is known as pseudo P pulmonale. Pseudo P pulmonale. While hyperkalemia shows tall T waves, and it shows a wide QRS complex. ST segment will be elevated, and P wave can become absent. While hypo and hypernatremia usually does not cause ECG changes, so usually typically no ECG changes. So answer is A option here. Question number 10. A patient has a backstride with absent Y descent in the JVP. What is the diagnosis? So the backstride is classically a triad of low blood pressure, distended neck veins, and soft heart sounds. That is typically seen in cardiac tamponade. And one more feature of the cardiac tamponade is the absent Y descent, which is very specific for the cardiac tamponade. And the treatment of cardiac tamponade is emergency pericardiocentesis. 11. A patient has a fixed white S2 split. This will be seen in. So the meaning of the fixed is that it does not change with the respiratory phases. It is constant with the respiratory phases, and wide means it is more than 60 milliseconds. So it is classically seen in cases of atrial septal defect. While in cases of the ventricular septal defect, it is a wide and variable split. S2 split. Variable means it changes with the respiratory phases. Question 12. Which of the following drug can decrease the mortality in heart failure with reduced ejection fraction? So the agent which decrease the mortality are known as the first line agents of heart failure with reduced ejection fraction. These include ACE inhibitors or valsartan plus sacubitril combination. Second agent is anti-aldosterons like spironolactone. Other agent include beta blocker, but very importantly, these beta blockers are which reduce the mortality are metoprolol, bisoprolol, and carvedilol. Not all the beta blockers. And number fourth is the SGLT inhibitors like DAPA or AMPA, gliflozins. So the answer here will be spironolactone. Propranolol is a non-selective beta blocker. It has not shown to reduce the mortality. Furosemide is only for the fluid overload, and digoxin is given when there is atrial fibrillation associated with heart failure, but it does not decrease the mortality. What is the immediate step in the management of diabetes ketoacidosis? So the immediate step is always IV fluids, because dehydration is the most common cause of death in diabetes ketoacidosis, and it will be immediately followed by insulin plus KCl infusion. So KCl infusion is given because insulin causes hypokalemia, so it is given even if serum potassium is normal. Then it even if it is normal, it should be given, because insulin will cause the intracellular shift of potassium. Question 14th, pre-tibial myxedema is seen in cases of Graves' thyroiditis. Do not mark it as hypothyroidism, because this pre-tibial is specific for the Graves' thyroiditis. In hypothyroidism, generalized myxedema will be seen. Question 15. Patient has hypertension with a predominant diastolic BP elevation without any peripheral edema. The ratio of the plasma aldosterone to renin is high, means aldosterone levels are high and they are suppressing the renin levels. So it means it is a case of a Conn syndrome. Conn syndrome is basically AAA, that means aldosterone producing adrenal adenoma. So therefore the aldosterone levels are high, and there is a diastolic BP elevation without edema because of the aldosterone has a escape phenomena. Escape mechanism is there. Whenever there is a fluid overload, ANP is released, and because of the ANP release, fluid overload is prevented in Conn syndrome. Hypothyroidism is high diastolic BP, no doubt about it, but it is associated with mixed edema. While hyperthyroidism is high systolic BP, predominantly due to high cardiac output, while Addison's disease present with low blood pressure, not high, low blood pressure. Question number 16. What is the preferred management of the acromegaly? The preferred management of the acromegaly should be surgery, but out of the medicines which are used are the somatostatin receptor ligands, and that we give is the lenriotide depot formulation can be given. Other which can be given is octreotide. It can also be given, but these days we prefer this depot formulation. Question 17th. A patient present with back pain. Lab test revealed a very high serum calcium and creatinine are high, and 40% plasma cells are seen in the bone marrow. So this is a classical case of a multiple myeloma, and you might get a lytic lesions skull X-ray typical, which is given to you skull X-ray for the multiple myeloma. Question 80. A patient has a weight of 60 kgs. What should be the maximum sodium in first 24 hours to be given if the presentation sodium is 110? So the sodium to be given in millimoles in first 24 hours, the formula is the desired sodium. So the desired sodium should be maximum to maximum of plus 10 from the presentation value. So it will be 10 multiplied by body weight and body water, and the body water is 0.5 into weight for females and 0.6 into weight for males. So it will come out to be 10 into patient is male. So we take 0.6 into 60 kgs. So it will come out to be 360. So 360 millimoles should be given in first 24 hours in millimoles. So the sodium should be raised by plus 10 from the presentation value. So this is plus 10. How it is coming? It is coming as a desired sodium concentration minus presentation sodium concentration. So our desired value is always plus 10 from the presentation sodium value, which is not included in a Q-SOFA score. Q-SOFA score is used for the diagnosis of septic shock, in which the parameter which are taken are respiratory rate of more than 22 per minute, Glasgow Coma scale of less than 15, and systolic BP of less than 100. If more than equal to 2 are present, that means it is suggestive of sepsis shock, septic shock. So answer here will be pulse rate is not taken into consideration. Question number 20. Which of the following is a feature of a gas bag syndrome? So the gas bag syndrome is seen when there is absolute relative or apparent erythrocytosis. Maybe because of dehydration, the RBC count can increase. So relative or apparent erythrocytosis. 21. Which vitamin excess can lead to the liver failure? So answer is niacin, that causes a fulminant hepatic failure. Excess of B6 causes neuropathy. B1 and B2 excess are toxicities are not known yet. Which parameter is not included in a MELD score? MELD score is for the liver transplant indication. So if the score is more than 18, then liver transplant is indicated. This include serum bilirubin, INR and creatinine. So albumin is not included in the calculation. Albumin is included for a child Pukes score. Child Pukes score. So the child Pukes score is also for the severity of cirrhosis. So in the child Pukes score, we take albumin, prothrombin time and bilirubin, as well as two important clinical parameter of encephalopathy and ascites. These 5 parameters are for child Pukes score. Question 23. A patient has a conjugated hyperbilirubinemia with liver enzymes being normal. What can be the diagnosis? Gilbert syndrome has unconjugated high bilirubin. Rotor syndrome is a conjugated high bilirubin. Viral hepatitis conjugated high bilirubin, but it has liver enzymes elevation, like SGPT will be elevated. Same with cancer of head of pancreas, conjugated high bilirubin will be there, but here the ALP will be elevated, obstructive enzyme. Rotor syndrome enzymes are totally normal. So answer is Rotor syndrome in this condition. Question 24. The genetic mutation in the Wilson disease, ceruloplasmin SS, this is not the genetic mutation, this is the levels are low. HFE is for hemochromatosis. ATP7A mutation is seen in Minky-Kinky syndrome, where copper deficiency is there, and 7B is for Wilson. So answer is C option. 25. A patient has fractured neck of fever and the patient was immobilized for 3 months. He present with breathlessness. What is the diagnosis? So the fractured neck of fever can have two possibility. One is a fat embolism, but fat embolism is early presentation within 24 to 48 hours, while venous thromboembolism is occurring after the 3 days of immobilization, where it is 3 months. So it is a possibility that patient presents with a breathlessness. So this it could be venous thromboembolism leading to pulmonary embolism. That is a possibility here. Question 26. A 50-year-old female presented with a cough, foul smelling sputum, and on examination, clubbing is seen, central cyanosis is seen, and lung crepitations are present. What is the diagnosis? So whenever in the clinical question you have this information of a foul smelling sputum, so always think of two possibility. One possibility will be a lung abscess, and the other possibility will be bronchiectasis. Both present with clubbing, both have lung crackles. So cyanosis is usually present in cases of bronchiectasis, cyanosis, unlikely in lung abscess. So the answer here will be bronchiectasis. Unfortunately, lung abscess is not written, which could be an important differential diagnosis in this condition. 27. Mesothelioma is seen after the exposure to this is classically asbestosis. Mesothelioma is the specific tumor seen in asbestosis. Asthma is anuria is defined as urine output of less than 100 ml per day, while less than of 400 ml per day is the definition of oliguria, and when it become more than 3000 ml per day, it is a definition of polyuria. Question 29. A child has a rash on the lower limbs, abdominal and joint pains with hematuria. The diagnosis is, so 100% patient have a rash on the lower limbs. Abdominal pain is due to intestinal vasculitis. Hematuria is suggestive of glomerulonephritis. So answer is HSP, Henoch-Colin purpura, and that is considered to be the most common vasculitis in children. Question 30. Antibody specific for drug-induced lupus is ANA will be the most common antibody, while anti-stone will be most specific for drug-induced lupus. While anti-DNA DNA is usually absent in drug-induced lupus, while anti-Smith is most specific for classical SLA. So answer here will be anti-histone. So these were the medicine question discussion for your CBT paper. All the very best for your exams.